questions is more statistics. How many vaping equipments and vaping materials has been surrendered through the bins and to voluntary purposes since they started the program? And secondly, how many of people have voluntarily came to HSA for help because they have already surrendered vaping equipment and need rehabilitations? And the third question is that moving on, which ministry or department will continue to coordinate the effort against vaping? Because I noted that the recent HSA annual report in the front page by the chairman, there's no mention about vaping. That's why I mentioned last round in my SQ previously.
As mentioned in my reply just now, 6,000 vapes and their components have been surrendered through the Bin the Vape program. More has been surrendered earlier, but we did not keep track of them. As for volunteers who gave up vapes, since we announced the new policies, 74 have come forward, as I mentioned in my reply. Which ministry will coordinate between MHA and MOH? We will work closely together to coordinate. The landscape have changed. Used to be people, either you smoke and vape or you take drugs, two separate set of people. But now you have a vape device, it's a delivery device that contains the drugs. The front end is controlled by MOH, controlled substance is regulated by MHA. So landscape have changed, the two ministries have to work closely together and coordinate this.
Thank you, Mr. Speaker. I'd like to ask the Minister, I think in his answer he said vaping, there's a high number of youth caught for vaping-related offences. According to news reports, these youths are enticed to vaping and peddling of vapes through social media channels. I'd like to ask how well is our HSA resourced to counter such tactics employed by the vape trafficking syndicates?
I think the challenge is not one of resource, but through the internet and messaging platforms, they proliferate very easily. And they do not necessarily have a presence in Singapore for you to be able to get hold of them and take them to task. So it's a big cat and mouse game. We will continue to do so. We have shut down so many of them. I reported it in my reply. And working together with IMDA as well as the tech platforms. But most importantly, the culture of avoiding substance abuse must take root in our society. So what has been very comforting is that ever since we launched this new whole-of-government approach to tackling intermediate vaping, the public has been very supportive. Schools, institutions, SSAs, even the youths amongst themselves are very supportive. So we hope we continue to uphold this behavior and this culture, and I think that is the best defense against substance abuse.
The government has, in view of the tightened measures to eradicate the use of vapes in Singapore, this also caused a shift into more underground activities. What is the government's measures to target this group of sales of vapes, especially the ones K-pods, in the underground activities?
Never think that just because we are worried about underground activities, so therefore legalize and regulate. That's what other countries have done when it comes to controlled drugs. And look where they are, and look where we are. And so I think we have always taken a tough stance against drugs. I don't know why I'm answering this, but I think it's the correct approach to take. Things do go underground, and MHA, with our laws, with our tough laws, will take very tough actions against them. So likewise for intermediate, don't fall for harm reduction arguments, ban it, enforce it, go underground, we'll go after you.
Thank you, Speaker. Much obliged. I understand that I did not file a PQ on this, but I'm just wondering if the enhanced stance against vaping will now, in fact, empower the SPF and not just the HSA to apprehend individuals reported to be using or distributing vapes. I asked because previously appeals I had written on behalf of residents to the SPF had been redirected. The concern, however, in doing so is twofold. The presence of HSA officers presumably is not as ubiquitous as that of the police, and HSA may not potentially have sufficient resources to tackle the search in cases, is something that Member Melvin Yong had also raised previously. I'm wondering, perhaps it's not within your ministry, sir, but I'm wondering if you could have your thoughts on that.
It's okay, we coordinate all these. In fact, more than the SPF. Today, SPF, HSA, ICA, CNB, NEA, LTA, Education, Casino Regulatory Authority, all the officers are empowered now to take actions against etomidate-related offences. The member mentioned there were instances in the past because etomidate fell between the legal cracks, which is why there was a point the SPF did not feel they are empowered to enforce, yet it falls under HSA. HSA find that our penalties, if we catch someone possessing or using etomidate, the penalties are not stringent enough, which is why we took the step of listing etomidate as a Class C drug in MDA. So we closed the loophole, but this is temporary. As I mentioned, early next year, we want to pass new legislation to make the necessary provision to enforce against this.
I thank the Minister for his clear response. I'd just like to reintroduce Subutex experience all those years ago. I remember we had to fill the gap for Subutex, and it took some time to fill the gap for Subutex before we could classify it as an illegal drug and then take enforcement action. I just see a little bit of similarity here with etomidate. I'm concerned at the level, at the length of time it took HSA to classify this as a Class C classification drug. I don't know the ins and outs of HSA. There could be a number of reasons why the experiments had to take so long or the policy considerations. But I'd like to know whether we had learned from the Subutex situation and whether or not we could have been quicker in reducing the amount of time it took to classify etomidate as a Class C drug. Because only then can you come in and do all the enforcement. Thank you.
The classification of etomidate under MDA is done under MHA. But I take the member's point. We have to act as fast as we can because the process do take some time. When a new substance enter a community, you have to observe who is taking it. Will it fizzle out or will it start to take root and grow? Ketamine, for example, didn't take root. At the same time, we have to observe the evidence, clinical evidence. Is it how harmful is it? How addictive is it? And how dependent someone becomes. So all this take a bit of time, but I take the member's point. We have to act as quickly as we can.
Mr. Kenneth Tiong.
There's a case in my division where the child is hooked on K-pods and expelled from school, refuses all contact with authorities. His parents want to know what powers do the authorities have to enforce compulsory assessment and rehabilitation for these youths that refuse all help.
Minister Ong.
The member wrote to me about this case. This is one of those cases that fell through the cracks during that transition period. So now, right now, with etomidate listed as MDA, we close the loophole. Next year, we have a new legislation.
Ms. Annie So.
Thank you, Speaker. I have two SQs. One is echoing from what parliamentary colleague Chris D'Souza have said. I would like to ask whether, apart from the etomidate laced vapes, has the ministry actually detected the use of other unlawful or harmful substances as well that may potentially be also eventually classified? The other PQ is pertaining to the MOE's recent announcements on introducing suspensions. In this regard, I would like to inquire whether are we exploring for these suspensions to be in-house, which means it's within the school, rather than external, as an effort to rehabilitate the students better. This is following from some of the feedbacks that we have gathered through the Woodgrove's anti-vaping task force that we have been engaging with the schools.
Minister Ong.
On the first question, I assume the member is asking whether there are other substances that are delivered through e-vaporizers. We have seen them in other countries, cannabis, for example. In Australia, we saw fentanyl. So we have to observe this carefully. And as Mr. D'Souza mentioned, be very vigilant, list them quickly, don't allow them to take root. As for the next question about MOE, I think MOE's answer on behalf of MOE. Their measures are over and above what the law has provided. So if a student is caught consuming, using etomidate through vaporizers, he will be required to go through the rehabilitation program, either IMH or one of our social services agencies partners. On top of that, MOE will, through their own in-house school discipline system, impose other punishment, such as suspension.
Mr. Dennis Tan.
The Minister to supplementary question. Would it be possible to include etomidate's precursors under the precursors control list? Number two, how do we ensure that the medical alternatives for etomidate do not get abused by drug addicts as an easy substitute? Thank you.
Minister Ong.
Precursors, I assume you meant the derivatives of etomidate. They are all listed as part of the Class C drug under MDA. They have already been listed. But if we have missed out something, do let us know, and we will include them. Second question, I think we just have to be tough on all forms of substance abuse so that one doesn't become the substitute of the other. This is an area MHA obviously know a lot better, but I think right now, as I mentioned, e-vaporizers changes the landscape. Now you got something very recreational, a delivery device, from delivering lychee-flavored nicotine to etomidate to something, to cannabis. So you have a range of stuff that can be delivered through this device. When someone is using a vape, you don't know what is he or she consuming. So because of that, MHA, MOH have to work closely together so that we cover all bases. So whatever substance abuse is out there, we take firm action against them. So one does not become substitute for the other.
I'd like to ask the Minister if Singapore has raised the issue of e-vapor product control in ASEAN forums, and what the responses from our neighbours been, and whether any collaborations have emerged thus far.
We have had some informal consultations, and we hope ASEAN at some point can take a concerted stance. Yeah, this is something that we want to work towards. In the meantime, we do see more and more ASEAN countries are banning vapes, Malaysia being the latest to attempt to do so. And we'll share our information, our experiences with them. Hopefully at some point we'll have a stronger ASEAN common stance.
Minister, to the extent that smoking is a precursor to vaping, and with the clampdown on vaping, does the ministry intend to take a tighter stance against smoking, especially among our young?
The good thing is that smoking prevalence has been dropping in Singapore continuously. The latest survey showed that prevalence amongst adults naming 15 and above, is 8.8%. It's a historical low and one of the lowest in the world. We will continue to encourage people not to smoke. And Singaporeans are responding to it. We should also remember tobacco has been around 200 years. Yeah. And when it first started, people do not know the harm that it can cause. Of course, today we know, but it has taken root and become part of society behavior. But we have to continue to work on reducing the prevalence of smoking.
Minister, you mentioned the involvement of IMH in these efforts to reduce our vaping issues. We clearly know IMH is very much involved with rehab and cessation programs too. With this expansion, how will it affect IMH's operational ability, given that we do have many cases of mental health also requiring attention, and especially if we see a surge in youth numbers coming forth, which is a good thing, but it also affects the system. Secondly, with regards to, are there plans for IMH to design dedicated youth-focused programs apart from the adult ones? Because we know that they respond differently to such and different such therapeutic approaches. Thanks.
IMH does a lot of things, different departments. So the Department for Cessation, which is called NAMS, they have their dedicated resources. So they will not be using resources that are used to treat or to help mental illness cases. That said, we are just starting our operation. If there's a need for more resources, we will beef them up. As for youth, we are working closely with MSF and the social services agencies such as WeCare, such as Fayette, who has experience working with youth, and they are already starting operations on cessation programs for youth.